what we want to do tonight in these preliminary talks is just sort of set the stage for not only what we're going to talk about over the course of the next couple of days, but to focus also on what are the big questions. And sort of the objective of our talks right now is in how do we treat metastatic disease right now, and where do we want to go? So I think in metastatic kidney cancer there are a few big questions. I think that sort of reflecting on this as on the trip down today, that we're maybe in a little bit of a stagnation period in kidney cancer, and I'll explain why. But when I approach a patient, I think many of you would agree, first question we have to ask is cure possible? It's a loaded question. It's a challenging one, not supported by, and I'm talking about metastatic disease, of course, not supported by level 1 evidence. But more and more, I think we are working with our surgical colleagues, radiation oncology colleagues, in the setting of oligo or low metastatic burden patients to consider things like metastectomy and local therapies in place of starting patients on systemic therapies. When we start with a systemic, when systemic therapy is the consideration, when is a consideration as well. And there's some data on that, and I think that it's becoming more and more clear that time is our friend and time is our patient's friends, and we can be more patient with systemic therapies. There's, of course, now the 10-year-old debate of TKI versus TKI versus TKI versus mTOR, and that is something that continues to be developed as a research question. I think that the bigger question now is, when is there an immunotherapy option, and how can we integrate the newer generations of immunotherapies into this disease that has long been known to be one that is sensitive to immunotherapies? And more, what is the histology is becoming, it's always been a relevant question, but I think that looking forward, one of the next great steps we need to take is the development of treatments for distinct histologies. Kidney cancer, it's interesting, when I was learning about it in medical school and residency, we always thought of it as this horrendously aggressive cancer, but the reality is it's actually quite a diverse disease. And this is a series of survival plots looking at burden of disease and a number of factors, and suggesting that multiple roads can be taken by our patients, and really trying to identify which pace the patient's disease is moving at is a very important initial consideration when we are confronting a patient with metastatic renal cell carcinoma. Interferon was the standard of care 10, 15 years ago, prior to the TKI era. We saw median survivals jump, in fact, maybe triple or go up by 2.5-fold once the TKI era hit. And we see data here with sunitinib, the compares data with pazopanib and sunitinib, and others trials demonstrate that we have made significant progress. But the other way to look at it would be to say, what about, and we can pat ourselves on the back for that progress that was made in 2005 and in the next few years. But you can also look at it and say that the overall survival advantages have sort of stagnated in metastatic kidney cancer. And yes, there's no shortage of trials to talk about, and we can talk about what are the details, and we can parse all of the risk factors in patients and whatnot in these trials. But the reality is we have not seen another jump since that period. And so I think that I would throw that out to our field as a challenge, and to say, how are we going to develop the next overall survival advantage or the next survival improvement in this disease. There's been a really nice series of studies looking at deferred therapy, and this is one thing that I wouldn't have thought of 10 years ago, and in 2015 it's become more evident. This is data put together from the Cleveland Clinic looking at patients who have a series of clinical factors that suggest that they could be potentially watched. In other words, patients who have measurable disease but do not have disease-related symptoms, and no prior systemic therapy. And these patients were followed with CAT scans every 3 months for a year, every 4 months in year 2, and then every 6 months, almost like the testicular cancer surveillance regimens that we learned. And initiation of systemic treatment only begins at the MD's discretion. And you can see this is data from Brian Reaney. I guess it is, there is an attribution there. But you can see, looking at a variety of different metastatic sites, who were the patients who were enrolled into this treatment approach, where they were watched and followed. And what was shocking to me was that the median time on observation from study registration to the start of systemic therapy was 14.1 months. These are patients with metastatic kidney cancer, and many of these patients are actually able to be watched for a longer period of time than that. And so I think that is reasonable. It's obviously sometimes a longer visit with the patient about watching and putting a patient on surveillance with a metastatic cancer. But I think these data and others support the fact that we can wait before initiating therapy. And the reason for that, of course, is not so much the cost of the therapy, but the potential toxicities of the therapy. And so that is one of the other big questions. With respect to the tyrosine kinase inhibitors, there's been a lot of data now looking at pazopanib, sunitinib, whether they are non-inferior, whether they are equal, and whether one should choose one over the other. In my clinic, I generally choose pazopanib as the first line of therapy. That's something that is true across our group. However, sunitinib has clearly a higher rate of response. And so in patients who might have symptomatic disease, for example, where you want to get the tumor to shrink and stable disease may not be your optimal outcome, it would be reasonable to consider sunitinib in that case. And I'll come back to sunitinib in a moment in my closing minute to talk about areas where the tyrosine kinase inhibitors can, of course, be optimized. Is there an immunotherapy option? Of course there's an immunotherapy option. Immunotherapy was the standard, if you want to call it that, for many, many years. Interleukin-2 and interferon were used well into the TKI era, and were in fact the control treatments in a number of the TKI studies. But the reality was very, very toxic immunotherapy, such as high-dose interleukin-2, benefited a relatively small minority of patients. And that's something that we've moved well beyond, but now immunotherapy is back with, in this case, nivolumab. Other PD-L1 inhibitors, as Dean suggested, are being exploited and explored. And while objective responses aren't occurring in every patient, I think we're going to see a lot of swimmer plots this weekend, by the way. They are durable, and that is, of course, a really key facet. And Dean's talk nicely pitches this in the framework of thinking about cure and whether or not a metastatic cancer can be cured. And certainly when one looks at the melanoma data with the very, very high rates of response and the extremely long durabilities of response, that's, of course, an encouraging thing to think about. So getting back to the tyrosine kinase inhibitors, one of the questions that we continue to ask is whether the exposure to the drug is right. And we talked about waiting to expose the patient to the drugs, but there have been a series of studies looking at sunitinib exposure and clinical outcome, and these are data from Bob Motzer and others, which have looked at area under the curve of sunitinib as it relates to time to tumor progression, as it relates to overall survival, as well as schedules of sunitinib, for example, looking at 50 milligrams, 4 weeks on, 2 weeks off, or the 37.5 continuous data. And it looks like the 4 on, 2 off regimen that was originally developed for this drug is the superior one. And the data below tend to support this, that when one gives a 4/2 regimen, you're actually inducing a higher trough plasma concentration. So with the VEGF receptor tyrosine kinase inhibitors, getting the drug to the target on a persistent basis appears to leverage a better response. And so I think that this is interesting data. I wouldn't say that we have optimized this issue yet, and certainly there are other drugs out there. Axitinib has also been studied in some detail with respect to the linkage or the connection between PK and dose and response. So finally, does histology matter? And of course the question there is, of course it does. But what we are seeing now are data that are looking at different histologies, including the non-clear cell histologies. There had been, I think, some enthusiasm early on that maybe the mTOR inhibitors might actually have a slightly more favorable series of benefits for patients with non-clear cell histologies. When one takes non-clear cell metastatic renal cell carcinoma as a as a basket and studies everolimus versus sunitinib, it looks like sunitinib is actually probably a superior approach based on progression-free survival in that setting. However, the progression-free survivals are not very good in the non-clear cell histology, and so histology does matter, and we need to see more approaches that direct this. And we're going to have some talks this weekend about the non-clear cell patients, as well as genomic profiling and other things that we can do in the setting of metastatic disease to improve our knowledge of what biology, what the disease biology that we are treating is. The ASPEN trial has been one that it was designed to look at this issue, sunitinib versus everolimus and metastatic non-clear cell pathology. There are subset analyses that look at which drug might be favored in which situation. Interestingly, in overall, it looks like sunitinib is favorable. However, there is a sort of a dichotomy or a paradox of good, intermediate, and poor risk. Seems like the everolimus, the mTOR path is favored in that group when one looks at this forest plot. You can see chromophobe and papillary subtypes here and begin to discern that there may be differences in outcome as we would anticipate in that setting. And so this is a series of questions that are now being asked in clinical trials. One could ask whether these are the right drugs to be applying to the non-clear cell histologies, and there are some people working on that will be addressed here over the course of the weekend. But for now, I think for the non-clear histology, most of the time I'm going with a TKI as opposed to an mTOR-based therapy. So we're going to hear more about kidney cancer on Saturday morning and throughout the day and throughout the weekend, and we have some really great speakers lined up to talk about this disease. And I'll just leave you with the concept that, as we all know, kidney cancer is a diverse disease. Deferred therapy, however, is reasonable and safe, and this is something where time may be your friend, and as we're well aware, toxicity of drugs is always a challenge, and in particular, if we can delay this toxicity, that may be a good thing. We may be able to make progress at the margins with the tyrosine kinase inhibitors by continuing to study and tweaking the PK. Immunotherapy is coming back and is, I would say, better than interleukin-2. I don't think we'll get much debate on that point. But we're going to have some talks on personalization of immunotherapies and biomarkers and genomic profiling of kidney cancer and how it may be integrated into the choice of when to initiate a novel immunotherapy and what those studies are going to tell us and when those drugs are going to be clearly available for this disease. So finally, we're learning that non-clear cell renal cell carcinoma needs to be studied more. It needs new drugs. It is a heterogeneous entity in and of itself. And although some may take issue, it looks like from the trials data that we do have that sunitinib should be considered a standard of care. So I bring up these topics simply to whet our appetite for more knowledge on kidney cancer over the course of the weekend, and look forward to those talks. And I'm looking forward to spending the next couple of days with all of you and learning from all of you, as I always do in these types of meetings. So I don't have the agenda either, but I think it's Walter who's up. Just taking a guess. All right, thank you much.